I'm Steve Edwards. I serve as President and CEO of CoxHealth. Today is Friday, January 7th, and we want to give you an update to both our staff and our community about what we think may occur with the emergence of the Omicron variant, what we're going to try to do about it, what challenges it has, and what we can ask of our community to help us. So you may have read or heard about the wave of patients that are hitting London hospitals. That's now happening in Missouri, as we've seen St. Louis and Kansas City hospitals at all-time COVID highs, and they're at near crisis point, and we find ourselves just behind them at a similar basis. So as an example, we look at the number of positive test results we have every day. This week we've had a day of 317 and a day of 412. We use those metrics to forecast the number of patients we expect in the future. We look at the number of new tests and we look at the percent positivity of those tests. If we apply the routine formula, which has been accurate for the last 2 years almost, we could anticipate 220 to 320 patients in our hospitals at any one time just with COVID. I think that number could be high because we understand Omicron may be more mild, but we're seeing hospitals still fill up, and we're seeing a lower number of ICU cases, but a danger as hospitals fill up, routine care is being deferred and delayed, and that's causing harm to patients beyond COVID patients. We are bracing for Omicron wave. We think it will be ascending for the next 4 weeks, and then perhaps a precipitous decline, which we've seen in other countries for the following 2 weeks, and then hospitalizations always kind of trail that. So here are our challenges. When we look at hospitals in London first, they almost immediately had a 10% vacancy rate of staff, because Omicron does find a way to get through vaccinated people. While they're not getting acutely ill, those that are vaccinated, they're not able to serve in the hospital because of quarantine rules. We're seeing hospitals in Kansas City now have 10% vacancy rates, and that may mean we will have departments with 10% up to 25% vacancy rates. So our big challenge is learning how to manage an increasing capacity of patients with decreasing staff availability. We are sufficient in almost every supply item, PPE, equipment, space, ventilators. So one of the challenges we have with supplies, the one supply item we're worried about is monoclonal antibodies. Those have proven to be highly effective at reducing hospitalization. They must be infused before severe symptoms occur. And so we've been very good about infusing up to 60 patients a day. We are on a federal allocation of monoclonal antibodies. They've become scarce. And so our current burn rate means we'll go through those and we'll exhaust that supply. So our physicians have worked together to create a prioritization, and the guiding principle is to direct it toward patients with the highest risk of hospitalization and death. And what are those factors in general? It relates to your immune status, it relates to age, it relates to obesity, and perhaps most importantly, your vaccine status. Quite frankly, if you've not been vaccinated, you're at the highest risk for hospitalization and death. And so all those symptoms we put together, all those factors we put together to determine who gets the monoclonal antibodies. I want to remind the community that to this day, we still see that 95% of all of our patients hospitalized due to COVID are unvaccinated. It's 95%. That's continue to be true throughout most of this pandemic. So what are we doing about it? Virtually every major division of our system is reorganizing, re-engineering their plans based on a 3-tiered approach of deepening severity. Each of those allow us to be more responsive to our community and chiefly with a worry about staffing. So I want to give you some examples. You're hearing about hospitals that are eliminating elective surgeries. That's not our plan. Our physicians have worked together to manage our surgical volume more evenly throughout the week. And so what I mean by that is hospitals typically have higher surgical volumes Monday, Tuesday, Wednesday, and they start to decline Thursday, Friday. Our physicians have worked together to smooth that out. And we look at those patients that are having an elective case are most likely to be admitted. And those that are most likely to be admitted, we're making sure they're spread out evenly throughout the week. So we will not reduce elective surgery. There is a second and third tier that would reduce elective surgery, and that would be chiefly based on those cases that we think would require admission. That's not our plan to do that, but that is a contingency plan. Our physicians are being amazing, I think, in their flexibility and support and coordination. So I want to give you some examples of what our physicians are doing. One, our primary care physicians are prepared to move their practices away from routine preventative care into more emergent or symptomatic care. So our primary care doctors are doing that. We know that there'll be a greater burden on our hospitalists and our pulmonologists, so we have other physicians that are reorienting their care back toward the hospital to support them. On a tier 3 example, our large 30,000 square foot super clinics are designed to be turned into a giant urgent care. So as we need to consolidate staff around the community and be more efficient, those centers could turn into large urgent cares. Our physicians would be willing to staff that. Also, our physicians who may become infectious can still do virtual visits if they're feeling well. And so they're geared up and prepared to stay home and do virtual visits if the demand calls on that. All of our support areas, all of our clinical areas have contingency plans as well. And one more example I would give you is if we have a large department that supports a hospital like engineering, there's probably 150 to 200 staff in engineering. Instead of focusing on routine maintenance and preventive maintenance, they can be reassigned to support the hospital in other ways, whether it be transporting patients or helping in other areas. They're prepared to do that. So now I want to talk a little bit about what you can do in our community. First, most importantly, is get vaccinated. If you're vaccinated, get your booster. And if you have not got your flu shot, please get your flu shot. The single most important factor reducing hospitalization and death from this disease is vaccination status. So please do that to protect yourself, protect your family, and quite frankly, protect our staff. Number 2 is bolster your immune system, vitamin D, vitamin C, zinc, and very importantly, sleep. This does not replace a vaccine. It can strengthen your immune system, but vaccine is the most important thing you can do. Number 3, plan on how to get your testing and how to get a home test. When you have that first set of symptoms, it's sometimes hard to put your head straight. And so to know where to get testing and how to get it done is important. Number 4 is we've realized you've got to step up masking, higher level, higher grade mask. We've learned that with Omicron, it's much more infectious. We know that in London, for example, it's out competing the common cold. And if you think of where you got a common cold, you probably can't remember, and that's how you'll probably get Omicron. You won't be quite sure how you got it. So it's aerosolized more than ever, and masking matters more than ever. Number 5, plan how to isolate. Think of each family member who could become ill and how will you deal with that family member in terms of isolation. Number 6, stock up on essentials, food, groceries, those things you might need. I think importantly, I would add a pulse oximetry to that list. That's a very simple test on your finger that just goes over your finger. It measures your saturated blood oxygen. That's a key indicator whether or not you need to go to the hospital. So think about getting that as well. Number 7, reduce risky behavior. This is going to spread very rapidly in the next 4 weeks. And so attending large events, congregated events, not masked, even masked is probably risky. So I would reduce those exposures as much as possible. And number 8 is we're going to have very busy hospitals, very busy ERs and urgent care. So we ask you to be patient, understand why we're busy, and maybe most importantly, continue to be kind to our staff and to others. Okay, so now I want to talk a little bit about what comes after this. We do expect this rapid increase of cases followed by a fairly precipitous decline. Every time a patient who has COVID is discharged from the hospital, we play Here Comes the Sun, and we've played that over 6,100 times. And so I want to talk a little bit about what I think can happen after this. So we think that those that don't become vaccinated, if you acquire the infection, it's much more likely you will acquire it. You will acquire some protection after that, and that's important as we look towards protecting our community overall. So you're going to get it, maybe the hard way. That protection, we understand, will make you about 14 times less likely to get Omicron again, and 4 times less likely to get Delta. And so as that wave goes over, I think it will wipe out Delta, and it will prepare us in a level of protection that will get our entire community better protected. I don't want to overlook the risk of long haul syndrome, so no one wants to get this Omicron variant on purpose. We don't know the long-term effect of it, but we do know long haul is a serious side effect of this virus. Lastly, I want to thank our community for the support you've given us over these last almost 2 years, for the respect and the love you've given us, and remind you that we're as strong as we are together. And this is a difficult time, the next 4 to 6 weeks, that we need to come together as a community to protect each other and to protect our community.